We are looking at the pathophysiology of heart failure, under which we have covered the RAAS system, the CNS, and the paracrine effects, the BNP, natriuretic peptides, and also the aldosterone mechanisms and all that. Now, there are three important things that you need to know in the events after a myocardial infarction and after heart failure also, particularly after myocardial infarction: remodeling, stunning, and hibernation. These might be short notes. Write short notes on stunning and hibernation. You may not know what is stunning and what is hibernation. Look at that. Myocardial stunning. See, you are stunned. Sometimes something happens, you are stunned. Myocardium is stunned. Stunned by what? Post-ischemic dysfunction. Suddenly ischemia has occurred and myocardium is stunned and starts dysfunctioning. There is a delayed recovery of the myocardial function despite restoration of coronary blood flow. Coronary blood flow is restored, but then the myocardium is still stunned. It has not come out of that stun. Delayed myocardial recovery even after the restoration of coronary blood flow. In the absence of irreversible, is it totally damaged and irreversible? No, it is just stunned. It will take time to come back. That is in the absence of irreversible damage. So now what is stunning? It is an event after post-myocardial status, post-ischemic dysfunction, delayed recovery of the myocardial function, despite adequate coronary blood flow restoration, absence of irreversible damage. Then what is hibernation? Hibernation is persistent myocardial dysfunction even at rest. That is, there is no acute event. There is chronic coronary artery disease is there, chronic stable angina is there, persistent myocardial infarction is there even at rest. Secondary to reduced myocardial perfusion. Sometimes there may be epicardial disease, sometimes there may be microcirculation damage. Function improves with revascularization, where in the above one, after revascularization, no improvement. Here, if you do a revascularization, the hibernation will go away. Cardiac myocytes remain viable in hibernation. That means there is no necrosis or apoptosis of the cardiac myocytes in hibernation. So now you understand what is stunning and what is hibernation. I hope you did. Now, let's go to the myocardial stunning and hibernation. Viable myocardium retains responsiveness to inotropic stimulation. Why I need to know? Viable myocardium retains responsiveness to inotropic stimulation. If the myocardium is dead, whatever medicine or injection inotropic, it is not going to act. If the myocardium is viable, it is ready for the inotropic stimulation. Can be identified. How do I identify stunning and hibernation? By resting ECG, resting echo, stress echo, thallium scintigraphy, stress thallium, PET scan, MR imaging with gadolinium scanning. So if at all you wanted to know a post-myocardial patient, is there any stunning, is there any hibernation? What we have to do, take stress echo, stress thallium, PET scan, MR image, gadolinium enhanced MR imaging. Revascularization may improve the overall ventricular function with beneficial effects on symptoms and of course on the prognosis. So with that, the pathophysiology part is over. Now we are coming into an area called clinical features, which day in and day out you people will be interested to examine and find out the heart failure. So what are the clinical features? This is the floor plan. Already we have covered the introduction, definitions, epidemiology, etiology, pathophysiology in 2 classes. This is the 3rd class where we are looking now at the clinical features. Clinical features, as all of you, there are symptoms and signs. All of you know clinical features mean symptoms and signs. What are the symptoms of heart failure? Dyspnea, orthopnea. What is orthopnea? Ortho is straight. Somebody is lying down, he feels breathlessness. Breathlessness while patient sleeps and he gets up in between in the night and starts panting for breath. You have to very clearly ask. They will not tell. If you ask me, do you have orthopnea? Will he tell? He will not know. But orthopnea, I don't know, sir. I have not gone to orthopedics. He will say. Orthopnea means when you are on the bed, are there occasions you get up in between in the sleep and you have to struggle for the breath, associated with coughing and breathlessness. This is orthopnea. Dyspnea is difficulty in breathing. Is dyspnea, paroxysmal nocturnal dyspnea. This is another extension of orthopnea. This orthopnea, or while he is lying down, the lungs will have pooling of the blood. Because of the pooling of the blood, the blood pressure increases and there will be dyspnea. That is the pathophysiology. It is paroxysmal, comes and goes. It is nocturnal. When the patient is in sleep, it is dyspnea. That's why it's called paroxysmal nocturnal dyspnea. Another important thing is exercise intolerance. Exercise tolerance is reduced. What does that mean? Exercise tolerance. Earlier, he used to walk 1 kilometer without breathlessness. Now, after 100 meters, he feels breathlessness. Earlier, he used to carry 5 kilograms of a suitcase in his hand. Now, he cannot even lift 1 kilogram in his hand. This is what is called the exercise tolerance. A woman who is in the kitchen, earlier I used to bring a very heavy pressure cooker from the stove down. Now I am able to not even lift the coffee cup, coffee filter also. He will say this is exercise intolerance and fatigue also. Fatigue, easy fatigability. They start to work within no time they get fatigue. These are all subtle symptoms. Patient may not say until you ask, is there any exercise intolerance? Is there any fatigue? Nocturnal cough. Anybody coming with a nocturnal cough must always suspect failure. What are the causes of nocturnal cough? Enumerate the causes of nocturnal cough. One. You tell one cause. Asthma. Asthma, daytime, nighttime doesn't discriminate. Anyway, cough will be there. Next one. Your turn. Why are you smiling? He smiles, you also smile. Is it infectious? Okay, tell. Nocturnal cough. You don't know. Yes, any pulmonary edema, PND, orthopnea, nocturnal cough. Next one. GERD. GERD, good. GERD is a very important. Yesterday, my wife was having 3-4 days cough, an unremitting cough. She didn't have any infection. She said, shall I start antibiotics? She was jumping. No. You start taking esomeprazole with imeprazole L. That is Sompraz L. 2 days she took yesterday night, today morning. After period. So, GERD, very common. Next. Cardiac asthma. Cardiac asthma is same as PND. Next one. Post-nasal drip and anything else? Tropical eosinophilic Loeffler syndrome, very common. Anything else? ACE inhibitors. ACE inhibitor cough is nocturnal. Okay. Now, whatever I told, you should try to write somewhere, otherwise you will forget it. Nocturnal cough. What are all the causes? We have enumerated 8 causes now. These are all the any other cause of nocturnal cough. Chronic sinusitis. They will have, when they sleep, there will be always an irritation of the pharynx. Chronic untreated sinusitis. So you remember all those things. Whatever we have listed, you write a list and then post in the group. Because tomorrow you will remember that you can check always in the group. Well, that's one good way. Okay, fine. Nocturnal cough is poor. What is wheeze? Wheeze, all of you know. Ankle swelling is dependent edema, anorexia, loss of appetite. So these are the symptoms of heart failure. What are the signs? What are the signs of heart failure? Tachycardia, heart rate is increased. Why, Why, madam, tachycardia is there? Why tachycardia? Simply heart wants to run or what? Heart pumping, SNS activity. What pathophysiology you have learned? Sympathetic nervous system overactivity is tachycardia. Pulses alternance. What is pulses alternance? Means what? One beat is stronger, the other beat is weaker. If you see the way, several times, just looking at the pulses alternance, the weakened heart, we have found out, and on the ECG we can see also very much. Increased JVP and ascites. Ascites is a sign, whereas edema is a symptom. Patient will not say ascites, he will say abdomen is bloated. Ascites, down and out apex beat. That is cardiomegaly. Right ventricular heave. How do you elicit right ventricular heave? Right ventricular heave.
parallel to the sternum.
Parasternal, and there will be a lift. The other way is take 3 fingers, second, third, and fourth spaces you keep in the fingers. Or you can do this first. So subtle one, I will always try to bring in with the 3 fingers, put in the second space, third space, fourth space on the just parasternal region. You just put it and then find out there is a slight heave. What is heave? What is heave?
Palpable.
Heave is a lift, pericardial lift and sustained lift. Lift should be sustained. It gets up just for a while, it stays. That is heave. Parasternal. Simple words only. You appear that you know, but you do not. That is the problem. So crepitations and wheeze, basal crepitations and wheezing, third heart sound. The presence of third heart sound is ominous in a heart failure. You should always look for the third heart sound. Edema, of course, edema, hepatomegaly, tender hepatomegaly. There is another sign associated with hepatomegaly. What is that? What does it mean? How do you elicit it?
For 30 seconds on the abdomen.
No.
And
While standing or while lying down?
While lying.
Patient should be lying down and put your pressure, not very harsh pressure because already tender liver. Just simply press it on the liver and you can see JVP increase already there. It will go up a little. Why? Why it goes? You also have a connection from the inferior vena or superior vena cava. Why only in heart failure?
Right heart failure.
Already the right atrium is overloaded. Right atrium is having more blood than normal. So any pressure here will increase the pressure, emptying into the right atrium, which goes through the superior vena cava into the JVP. Okay, this will be asked in the exam. That is why I am asking. Cachexia and wasting. So weight gain initially, the cardiac cachexia, loss of weight later in chronic heart failure. Simply speaking, this is a phases. You see the phases. What is phases? If you remember the acronym phases, this is coined by the European Heart Association. Fatigue. When the heart cannot pump enough oxygen-rich blood to the body, muscle and tissues feel tired and weak, even at rest. Activities are limited. Simply daily tasks like grocery shopping, climbing a flight of stairs, walking to the mailbox, all this become a big exhaustion. Cardiac chest congestion, edema, shortness. Remember phases: fatigue, activities limited, chest congestion, and then edema or swelling. Either where do you look for the swelling? Where do you look for the swelling? Dependent area. Suppose the patient is sleeping. Will I check the ankles? No. Sacral edema. We have to say. Sacral edema, ankle edema, where dependent position edema, shortness of breath, of course, dyspnea, orthopnea, paroxysmal nocturnal dyspnea. And patient usually uses 2-3 pillows to make himself slant and comfortable. And that is the position you are supposed to adopt for the patient in the hospital also. Okay. Now, common causes of lower limb edema is a standard short notes question for any postgraduate or in the YOS. Describe the conditions which can produce lower limb edema. Gravitational edema. Immobility. Somebody is immobilized and leg is down, or you go to the America from here and sitting in the airplane. By the time you get down in New York, there will be dependent edema because the legs are hanging. Along with that gravitational, you also have gestation, which is not in this slide. Gestational edema is a very common form of lower limb. The slide, somehow that was not typed, I am adding it now. Gestational edema. Congestive heart failure, of course, venous insufficiency, varicose veins, venous obstruction, venous thrombosis, thrombophlebitis, phlebothrombosis, hypoproteinemia. Hypoproteinemia can be liver hypoproteinemia or nephrotic syndrome. That is, liver is not producing enough protein, hypoproteinemia. More protein is lost through the kidney, nephrotic syndrome. Lymphatic obstruction, filarial obstruction, or any other acute lymphangitis can produce. What are the drugs which can cause? CCBs and NSAIDs. The moment put a patient on hypertension on a CCB, nifedipine, sir, your tablet is all right, BP is lower, but my legs are swollen. Side effect of calcium channel blockers. And also any NSAID use can increase the pain. These are the drugs which should not give in heart failure because they increase the blood volume. So now this is what are the common, there are some rarer causes will be there. Common causes of lower limb edema, gravitational edema, gestational edema, immobility due to various causes, go and attend and come back, congestive heart failure, venous insufficiency. That was like a lesson I have told. Varicose veins, venous thrombosis, obstruction, hypoproteinemia due to liver or nephrotic syndrome, lymphatic obstruction, and then drugs like CCBs and NSAID. Okay. Suppose there is peripheral arterial disease, will it produce edema? Peripheral venous disease, I understand it is listed. There is a PAD, peripheral arterial disease. I'll tell that also in the classes. PAD is a very important topic. PAD. Will it produce edema? It produces even wasting, and in the sense that the limb will be dry, and also limb will have a skin changes, dryness, and they will not have edema. Okay, now this is again from the International European Society. Okay, European Society of Cardiology websites. This one. Typical symptoms, less typical symptoms. Typical signs, less specific signs. You should look for. Typical symptoms are breathlessness, orthopnea, PND, reduced exercise tolerance, fatigue, tiredness, increased time to recover after exercise, and ankle swelling. These are very typical. What are the atypical presentations of heart failure? Less typical ones: nocturnal cough, wheezing, bloated feeling, loss of appetite, confusion, depression, palpitations, dizziness, syncope, and bendopnea. What is bendopnea? Bendopnea. Pnea is breathing. Patient tries to be like that and then breathe because of the heart failure. That's very rare, not very common. Signs: elevated jugular venous pressure, hepatojugular reflex, third heart sound, gallop rhythm, laterally displaced apical impulse, down and out apical impulse. Less specific: weight gain of more than 2 kilograms per week, weight loss in advanced heart failure, tissue wasting and cachexia, cardiac murmur, peripheral edema, ankle scrotal and sacral. Sometimes when the patient is lying down, you can look for sacral edema or scrotal edema also. Pulmonary crepitations, reduced air entry and dullness and percussion at the lung bases due to pleural effusion, secondary to heart failure, tachycardia, irregular pulse, alternance pulse, tachypnea, Chinese strokes respiration. What is Chinese strokes respiration? Huh? Hyperapnea, slowly coming down to hypoapnea to apnea, and then hypoapnea, hyperapnea, like that. Like that, slowly it comes to hypoapnea and again goes to this is called Chinese dose breathing. Okay, hepatomegaly, ascites, cold extremities also very important, and also you have the oliguria and narrow pulse pressure. In heart failure, why the narrow pulse pressure? Vinay, why is the narrow pulse pressure? Systolic output is reduced. Systolic blood pressure is lower. Diastolic unaffected. Right. Okay. Should understand each clinical sign. Okay. Now, diagnostic algorithm for a patient of the diagnosis of heart failure, non-acute onset. It is not acute heart failure we are thinking, non-acute patient with suspected heart failure. That means non-acute onset. What do you do? First one, assessment of heart failure probability. Does this patient have heart failure? What is the probability? clinical history. History of CAD, he had a myocardial infarction, he had revascularization last year, last day, yesterday, history of arterial hypertension, already hypertensive, exposition to cardiotoxic drugs or radiation, use of diuretics already is using, orthopnea, paroxysmal dyspnea. These are clinical history. Physical examination, basal rails are there, bilateral ankle edema is there, heart murmur, JVP raised, laterally displaced, broad and apical beat. ECG, any abnormality in the ECG, you have to suspect heart failure. What do? Immediately, when you have suspect heart failure, the first test that you do, natriuretic peptide. Okay? Anyone more than one of those above present, you do natriuretic peptide, anti-pro-BNP of more than 125 and a BNP of more than 35 is indicative of heart failure. Supposing you don't have the technology or you are in a peripheral center, primary health center, no anti-pro-BNP is done. Assessment of natriuretic peptide is not available, then do an echocardiogram. Okay, first step is not echo, do anti-pro-BNP. If anti-pro-BNP can have normal, there is no elevation, heart failure unlikely, and all the symptoms are absent, then also heart failure is unlikely. Anti-pro-BNP is, of course, it is elevated, then you do an echocardiography. Echocardiography is normal. That means anti-pro-BNP is very specific but not sensitive. Anti-pro-BNP, if it is elevated, it will tell you, but it is not sensitive because it has to be confirmed by the echocardiography. There are other causes of increased anti-pro-BNP. That is why anti-pro-BNP will only help you to diagnose. If heart failure is confirmed based on the available data, determine the etiology and start appropriate treatment. Because heart failure treatment is one, improve the symptoms, two, treat the underlying disease. Now you tell, what do you do when a patient suspects the heart? How to suspect heart failure? Not able to read. Read louder, not to yourself, to others.
Clinical history. History of coronary artery disease. Myocardial infarction, revascularization. History of arterial hypertension.
Exposition to cardiotoxic drugs.
Or radiation. Use of diuretics. Orthopnea or paroxysmal nocturnal disease.
Yes. These are the symptoms. In the physical examination, you read.
Physical examination, the patient is having raised bilateral ankle edema, heart murmur, loud history sound, jugular venous dilation, and laterally displaced are
broad and of course, any ECG. What do you do first step? What is the first step you do? Do anti-pro-BNP. What are pro-BNP? Between them, what to choose, I will tell later. Anti-pro-BNP cutoff value is 125 picograms. BNP cutoff value is 35 picograms. No, I'll tell you. I'll show you that anti-pro-BNP separately will deal. Just for that, more than 125, more than 35, you keep as the cutoff. If they are normal, heart failure is unlikely. If none of the symptoms are there, heart failure is unlikely. Suppose this one or more of the symptoms is there and anti-pro-BNP is also elevated, then you do a echocardiography. Echocardiography, ejection fraction you look at and see whether there is heart failure or not. Okay. If heart failure is confirmed, you must look for the disease, particularly structural heart disease, valvular heart disease, ischemic heart disease, cardiomyopathies, pericarditis, all structural diseases you have to look for. Okay, now. How do I diagnose now? Staging of the heart failure. You are suspected, you did ECG. Heart failure, you have diagnosed. But without staging the heart failure, you cannot go further. How to stage the heart failure? Stage A. That is, this fellow doesn't have any clinically manifest heart failure. Those at high risk of developing heart failure, like for example, hypertension and diabetes, high risk group for heart failure. He is not at heart failure, but is in stage A, high risk patient for heart failure. Who are those? Those with established coronary artery disease or hypertension or diabetes or previous history of heart failure. Stage B, asymptomatic LV dysfunction. Patient with structural cardiac disease who have not yet developed heart failure. That means there is a cardiomegaly, there is some other abnormality in the ECG or echo. They have not yet developed, but they have already got asymptomatic LV diastolic dysfunction, LV systolic dysfunction. Stage C, symptomatic LV dysfunction. Patients with current or prior heart failure symptoms, treatment history, or prevent and stage the ESHF, ejection fraction, reduced ejection fraction, heart failure. Stage D and stage heart failure, those with terminal heart failure and have very poor outcomes. So I classify patients as stage A, stage B, stage C, and stage D. This is very important. Now, where is my focus? Should I focus on stage C and stage D or stage A and stage B? That is where the prevention can happen. So you have to pick up those fellows in stage A and stage B, see that they do not progress up to stage C and stage D. Okay. Criteria for diagnosis. To satisfy the diagnosis of heart failure, there must be appropriate symptoms. Already we have listed the symptoms. Objective evidence of cardiac dysfunction. What is the objective evidence of cardiac dysfunction? Pro-BNP, anti-pro-BNP, ECG changes, echo changes. In case of doubt, appropriate response to treatment. Echocardiography is the most practical tool to demonstrate cardiac dysfunction. What else you do? Anti-pro-BNP, echo are already there in the list. ECG you have to get, CXR, blood count, CBC, renal function, LFT, thyroid function. Pulmonary function also is required. Why? To exclude lung disease. Because dyspnea is a feature of lung disease as well as heart disease. Now you said 15 minutes back, cardiac asthma. How do you differentiate cardiac asthma from bronchial asthma? You said bronchial asthma, you said cardiac asthma. Now you both differentiate. Bronchial asthma, seasonal, paroxysmal, recurrent, and then people will have lower or higher pulmonary function abnormalities, reversible with bronchodilator. And there is no paroxysmal nature. There is in the night, no PND, no orthopnea. No can occur either sitting or standing. Whereas here, usually associated other features of heart failure, paroxysmal nocturnal dyspnea, and then also the orthopnea will be there. The wheeze is not that an important symptom. Their wheeze is a very important. Here crepitation is more, there bronchi. Bronchi and crepitations, you know the difference? Now what is bronchi? Where do they arise? Airways. Crepitations? Yes, correct. So crepitations are wet sounds, bronchi are cooing sounds. Okay, right. So in bronchial asthma, what type of bronchi you have? Expiratory bronchi or inspiratory bronchi? Bronchial asthma is air out disease. Difficulty in breathing the air out. Expiratory bronchi will be there. Okay. Whenever you find crepitations at the base, you have to ask the patient to cough gently and post-tussive crepitations you have to see. Some crepitations are possible because of lying down and stasis. If you cough out, that secretions will get emptied, and post-tussive crepitations means there is persistent fluid still left in the pulmonary parenchyma. So post-tussive crepitations are important. Okay. Some clinical aspects also I'm telling. So heart failure is not a diagnosis. Fever is not a diagnosis. Joint pain is not a diagnosis. Itching is not a diagnosis. You have to find out the reason. Heart failure is not a diagnosis. If I say, what is your... No, heart failure. That means nothing. What is the heart failure? What stage he is? What underlying disease is there? All those things you have to tell. It is multifactorial syndrome. Confirmation of the heart failure is important. What type and what stage? Causes of heart failure must be ascertained. Comorbidities and precipitants must be looked at. Okay. So there are 4 classes: NYHA classification, New York Heart Association classification of heart failure. NYH class is very important. Just as you have staged it, asymptomatic, and then already cardiac damage is there, but not at heart failure B, then C and D you have seen. That is the staging. Here the classification based on the symptoms. Asymptomatic, no symptoms of, no limitation in physical activity, no fatigue or SOB despite of the presence of the heart disease, only echocardiography. Stage 2, slight limitation of physical activity, more strenuous activity causes SOB, walking on steep inclines and several steps. Stage 3, more marked limitation of physical activity, which interferes with work, even level walking produces symptoms, and at rest patient is still okay. Stage 4 is patient is breathless and has symptoms even at rest and cannot do even normal household work also. This is very important. You have to classify the heart failure according to NIH. Now, there is one more classification called KILIP classification. When do you use NYHA? When do you use KILIP? NYHA in chronic heart failure. KILIP is an acute heart failure. You should not go and apply KILIP in chronic heart failure, nor NYHA in the acute heart failure. Class 1, no LV systolic dysfunction, 6% mortality. Class 2, has 3 gallop present, mild pulmonary congestion, mortality is 30%. Class 3, acute severe pulmonary edema, mortality is 40%. Class 4, cardiogenic shock syndrome, mortality is 80 to 90%. Heart failure is a very high mortality disease. If the KILIP classification is 3 or 4, we risk a very great. Class 1 is no LV systolic dysfunction, mortality is less. So, concept of a diagnostic test time, generally, any diagnostic test, sensitivity, specificity, negative predictive value, and positive predictive value. You may not know them correctly. That's why I'm putting this thing. A test or a sign or a symptom, sensitivity need not be only test. It can be about a sign. It can be about a symptom also. What is the sensitivity of lower limb edema? If I ask, what is the specificity of lower limb edema? What is the sensitivity of tachycardia? What is the specificity of tachycardia in heart failure? Like that, sensitivity and specificity can be for the test, for the sign, and also symptom also. Sensitivity is the ability to rule out disease if normal. That means if the test is normal, you can very strongly say this disease does not exist. Give me one example. Test is normal, disease is excluded. Give me one example, not related to heart failure.
Like this.
Somebody came with a cough and breathlessness. You took an X-ray test. X-ray test is normal. It mostly excludes disease. Severe pneumonia or anything. There may be some other diseases it excludes. A sensitive test, the test is normal. It excludes disease. Okay? So you gave a blood smear for malarial parasite. Lab reported negative. Can you rule out malaria? Because a negative test cannot rule out malaria. Isn't it? Malaria is not, blood smear is not a sensitive test for malaria. So you find a malarial parasite. Can you say it is definitely disease? Yeah, yes, specific. So blood smear is a specific test for malaria. It is an insensitive test to rule out disease. Okay. You just give sputum for examination for AFB. Sputum AFB negative. Can you rule out disease? No, it's not a sensitivity test. It's positive. AFB are demonstrated. It's a specific test. So sensitivity is ability to rule out disease. Specificity is to rule in disease if abnormal. Rule out disease if abnormal. If the test is normal, rule in disease if it is abnormal. Okay. For example, you did an MRI of the brain after a head injury. Is it a sensitive test or a specific test? Suppose MRI is normal. We can rule out. If it is abnormal, we can rule it. So it is both a sensitive test and also a specific test. Okay? If you go for high sensitivity, high specificity together, the cost will go up. That we have to remember. Negative predictive value is a test or a sign or a symptom, ability to negate the disease if it is absent. If that sign is absent, you can negate the disease. Suppose there is no edema. Can I rule out heart failure? Suppose there is no edema. I cannot. Yes, the negative predictive value is not good. Okay. So positive predictive value. Suppose somebody has got basal rails and orthopnea. The positive predictive value is very high. That means that particular sign and symptom, most likely it will be a heart failure. This is the concept you understand. Now you see, against that I am showing the value of clinical features in heart failure. Nobody will tell you clinical features also sensitive to specificity. Clinical features do have sensitivity and specificity. Look at the shortness of breath. Sensitivity means ability to rule out disease. Patient doesn't have shortness of breath, 66%. Orthopnea doesn't have, it cannot rule out. P&D, pedal edema, chest X-ray. Specificity is there. Symptoms you see, the tachycardia is not there, you cannot rule out. Crepitations are not there, you cannot rule out. Tachycardia is there, you can almost be certain. Crepitations are there, you can be certain. So these are specific symptoms, but very less sensitive symptoms. They cannot rule out the disease, but they can confirm the disease. Likewise, these the symptoms are also very good in confirming the disease, but they're very poor in ruling out the disease. Okay. Echocardiography, electrocardiography. What is the sensitivity of the electrocardiography? 94% sensitive. A normal ECG excludes heart failure. If it is sensitive, it should exclude heart failure. Confirmation is only 61%. An abnormal ECG may not confirm the heart failure. Positive predictive value 35%. Negative predictive value, normal ECG 92%. Abnormalities of ECG. What are the abnormalities of ECG in heart failure? You must ask. You may be asked. What abnormalities I should look for in heart failure? Evidence of present or previous MI. Left ventricular hypertrophy, most important predictor. Atrial fibrillation or other serious arrhythmia. Bundle branch block. Left axis deviation. Okay. Bundle branch block of new onset bundle branch block is very important. Electrolyte and miscellaneous changes. What are the electrocardiographic changes you will look for? 1. Evidence of previous or present myocardial infarction. 2. Left ventricular hypertrophy, atrial fibrillation, other serious arrhythmias, bundle branch block, particularly new onset, means previous ECGs are normal, today ECG is showing bundle branch block. Left axis deviation, electrolyte and miscellaneous changes. Now, European Society of Cardiology, American Society of Cardiac Association, American Heart Association, National Institute for Clinical Excellence, all these are international bodies. Heart failure symptoms and signs, cardiac dysfunction, response to treatment, confirmatory test. Okay, symptoms and signs are one side. Cardiac dysfunction test, normal BNP, NPV, 98% it is sensitive. And then normal CXR, negative predictive value is 50%. CTR more than 50%, plus pulmonary congestion is also very important to look at. Now, look at the ECG here. A 24-hour Holter may be required because these arrhythmias may not be there. They may be paroxysmal arrhythmias. In order to pick up, you have to ask for a 24-hour Holter. If 24-hour is not adequate, sometimes you ask for multi-day Holter. Multi-day Holter means 48 hours, 72 hours, you can see. For arrhythmias which are not very commonly occurring, you have called what is called implantable lead recorder, ILR. They implant a lead here and record it for 1 month. But Holter you can't keep for 1 month. So if you any very rare arrhythmias, you have to have ILR. Okay. Atrial fibrillation is very important for the prognosis of heart failure. Atrial fibrillation, irregular heart, tachycardia will be there, and the RR intervals are varying. No P waves are seen. P waves I have to look at in VL3 and V1. I don't have any P waves seen, instead flutter waves are, fibrillary waves are there. Now, Look at the atrial fibrillation in heart failure. There are several studies, atrial fibrillation in heart failure, solved 92, 91, different studies, and they have identified functional class 1, 2 to 3, 3 to 4. But if you have functional class 1, the patients in percentage is only that many. But functional class 4, you have already a patient on 50% of patients. Or in that, in various studies, you can see the functional class versus percent of patients. Now, this is a very profound statement. Still, it is a gold standard test. A single most useful diagnostic test in evaluation and management of patients with heart failure is the comprehensive two-dimensional echocardiogram coupled with Doppler flow study. So every patient of suspected heart failure must get the benefit of getting an echocardiogram done on the same sitting. So what do I look for? An echocardiogram. It is a single most useful non-invasive test to quantify systolic function, ejection fraction. I told you what is ejection fraction last time. What else I should look for? Regional wall motion abnormality, pulmonary arterial pressure. So what are the important things? EF, RWMA, pulmonary arterial pressure. To confirm the diagnosis and the need for ACE inhibitors. Immediately, if the confirmation means immediately ACE inhibitor has to be given. To identify diastolic dysfunction and right ventricular dysfunction also sometimes may be there. Identification and assessment of valvular heart disease, VHD, and pericardial effusion. It is a prognostic tool to document improvement also. Last time ejection fraction 30%, now after treatment now it is 50% prognosis. Assessment of embolic risk also, because intra-atrial thrombus, it poses risk for embolism. Mural thrombus also we have to see. All patients with signs and symptoms of heart failure, echocardiography is a must. Shortness of breath in with a murmur, atrial fibrillation, high risk, AMI, arrhythmia, heart failure, all should be thought. What are the things I look for? RWMA, systolic function, ejection fraction, pulmonary arterial pressure, diastolic dysfunction, RV dysfunction, valvular heart disease, pericardial effusion, and embolic risk and thrombosis, intra-chamber thrombosis also you should look for. Now comes the important test called the BNP and T-proBNP. It could be a short notes, BNP and anti-proBNP. So pro-BNP is 108 amino acids total. It's all a peptide chain. So 108 amino acids are there. And what happens at 76, if you cleave, there will be 1 to 76 and the remaining will be there. 1 to 76 is the N terminal of the pro-BNP. That is 1 to 76. Remaining 32 are the BNP, B-natriuretic peptide. So either you estimate BNP, which means the second bit, or you estimate the first bit, which is the 76 amino acids. Anti-proBNP, BNP measurement are one and the same. You are cutting into two pieces. The first bit you estimate anti-proBNP. Second bit you estimate BNP. First bit has got 1 to 76 amino acids. Second bit has got the 32 amino acids from 77 to 108. Otherwise, both are same. Then why two tests? One test is sufficient. There is a reason. Why? We'll see. You see here, this is the A natriuretic peptide. This is the B natriuretic peptide. This is the C natriuretic peptide. This is the D natriuretic peptide. Actually, 4 types. So what happens? And there is a ventricular stretch or ischemia produces this. But there is a cleaving here. This is the remaining bit, that is the 32 amino acid bit. The remaining 72 amino acid bit is this one, cleaved by an enzyme called the corin. An enzyme corin cleaves it into two, the BNP part and the anti-proBNP. The bigger bit is the anti-proBNP, the smaller bit is the BNP. Now, I'll skip this slide. Now, BNP to measure is usually, it is not, you require longer time to get the result. Okay. Second thing is BNP is not very stable. You have to immediately look for it. If you wait and do the blood test, BNP values may be different. Whereas NT-proBNP results are faster and you don't have to immediately do it. You can do it at a later stage. So if the lab is far away, let us say from a peripheral village he is sending, he must ask for NT-proBNP because time will not affect it. So for that reason, you have two tests there. BNP is stable in whole-blooded room temperature with addition of EDTA 20, whereas anti-proBNP is stable for 72 hours in whole-blooded room temperature. Requires no additives. Both are not stable during freezed conditions. When you are transporting a sample, anti-proBNP has got an advantage. Okay. BNP is the leukocyte count of heart failure. At best, one-third of the emergency rooms have access for echo. But BNP is now available as a point of care test, just like hepatitis test or pregnancy card test. We have a card test for the BNP also. Because if all you need to buy the kits there. You used to do COVID test at home. Like that, it is available as a card test. BNP and PNP are in response to the stretch of the left ventricle. In BNP study, BNP is highly predictive of heart failure. BNP separates heart failure from other causes of shortness of breath. BNP and anti-proBNP have same sensitivity, same specificity. The advantage is anti-proBNP you can wait and transmit later, result is obtained faster. Whereas BNP result takes time and you have to process the sample immediately. Raised BNP is a powerful predictor of mortality. In mitral stenosis and treatment of patients with heart failure, BNP values are generally low. BNP increases with age. BNP in males is more usually than in the females. In mitral stenosis, BNP values are low because mitral stenosis does not have greater stretch of the left ventricle. The BNP is dependent upon the left ventricular stretch. Okay. Now, you see, pressure or volume overload is there. That produces stretch of the left ventricle. That produces BNP. BNP is a vasodilator and then it inhibits the sympathetic activity. Okay. BNP is protective because it releases the vessel from constriction. It's a vasodilator and also it inhibits the sympathetic nervous system. What are you looking?
Yes.
Concentrate on the class, not in your mobile. Okay. Natriuresis and diuresis will produce. What will happen? The BNP will act on the kidney and produce sodium excretion and diuresis and also inhibits the RAS. How is BNP active? BNP is a vasodilator. BNP suppresses the sympathetic activity. BNP produces natriuresis and diuresis, reduces fluid overload. It also inhibits the RAS system. That means it acts on all the mechanisms of the pathophysiology of heart failure. Now, clinical examination, chest X-ray, echocardiography, natriuretic peptide. I told you point of care, triage BNP, the biosite, it is called. Cardiac reader anti-proBNP is also available. Biosite is the brand name for that card test. Natriuretic peptides are there. BNP less than 100, 100 to 400, more than 4. Anti-proBNP less than 400, 400 to 2000, and more than roughly around 4 to 5 times than the BNP. Chronic heart failure, unlikely, uncertain diagnosis, chronic heart failure, like the cutoff values are there. Now, see, BNP and NYH class. Supposing the NYH class is 1, BNP is very low. NYH class 4, BNP is very, very raised. That means it correlates with the class symptoms also. NYH class is NYHA class is a symptom-dependent classing, and BNP is a direct predictor of the severity of the disease, as you can see from the slide here. So BNP and B-natriuretic peptide, sensitivity and specificity, positive predictive value, negative predictive value, and accuracy of B-natriuretic. Anything less than 100 BNP, above 100, 90% sensitive, 76% specific, 79 ppv, 89 NPV, 83 accuracy. So, cutoff point for BNP is usually 100 we take. Now, Cardiac causes of borderline BNP. What are the causes in which BNP can increase without there being heart failure? This will be a thing you require to know, because all patients of BNP increase are not heart failure. There are certain conditions in which BNC will be increasing, but there is no heart failure, like cardiac causes, MI, atrial fibrillation, acute coronary syndrome, valvular heart disease, cardiac conversion, myocarditis. These are the cardiac causes. What are the non-cardiac causes? AKI, acute kidney injury, chronic kidney disease, hypertension. Pulmonary hypertension, severe COPD, pneumonia, pulmonary embolism, ERDS. Old age, female gender, liver cirrhosis, hyperthyroidism, sepsis, and chemotherapy. These can produce a marginal increase in the BNP, but not in thousands as in case of heart failure. You have to be very careful for calling a BNP as positive result. If BNP is elevated, there are no other signs of heart failure. Echo is normal. You must look for the other conditions listed here. This will be a common short notes. Discuss the BNP. Means you have to say what is BNP, what is pro-BNP, what is the advantage, those cleaving there, the two parts business, which is important, card test is there, you have to say. What are the causes of borderline BNP increase also you must discuss. Now, are there markers, biomarkers today in the management of heart failure? Are there tumor markers? Do you have any markers for tumor? Now tell me a few tumor markers.
CA 120.
120.
CA
CA? 90. No.
A 99.
Anything else?
Prostate.
Anything else? Madam, sleeping madam. Any tumor markers you know of? You have to be attentive, you can't be sleepy. Any tumor markers you know? Alpha fetoproteins. Very good. Okay. So these are some of the tumor. Like that, are there any cardiac dysfunction markers today? Look here. Uric acid, myeloperoxidase, they tell about the oxidative stress. Okay. Neuroendocrine, this one, MR and pro-ADM, peptin and endothelin, that tell about neuroendocrine problem. Troponin and cardiac creatinine kinase and H-type FAB receptor. FAB is fatty acid bridging protein. So these are the for about myocardial injury. There is renal injury, creatinine, cystatin C, electrolytes, and NGAL. NGAL is neutrophil gelatinase associated lipoctin. Okay, fibrosis and matrix remodeling, S22 and galactin 2 and metalloproteases. Inflammation, HSCRP, interleukin 6, ST2, human necrospectral alpha, and procalcitonin. Whenever you have a doubt about infection, you send for procalcitonin, isn't it? So that is why, in a case of heart failure, some of these markers may come handy to know whether there is oxidative stress, whether there is neuroendocrine excess, whether there is myocardial injury already there, like that's a drop test you do. The renal injury, like fibrosis and matrix remodeling, any inflammation is there, any chamber dilatation, of course, natriuretic peptides. This is very important for you. These are the new markers for various pathophysiological changes that occur in heart failure. Okay, now radiology. Go to CT chest, CT of the chest. I have to look at the cardiomegaly. How do you measure cardiomegaly in this? How to measure cardiomegaly in a chest X-ray? Now, how to measure first of all? 5.5 and all, you know, that's cut off. No, I'll show you. See, none of you would have known. Now you see there. Draw a vertical line perpendicular, parallel to the trachea there first. Trachea will be the tracheal tube. Just draw a line there. First one line. Then you draw the distant line between that line and the right border of the heart. That is A. Then from that line, you draw another horizontal line to the left border of the heart. Then A plus B you add. Okay. And then you take the width of the chest. at the highest width of the chest in the chest X-ray. That is C. A plus B by C is equal to cardiothoracic ratio. You understand? Not simply the cardiac. You have to see the cardiothoracic ratio. This is the procedure of calculating CTR, cardiothoracic ratio. Vertical line you draw, from that vertical line horizontally towards the right border of the heart, A. Left border of the heart, B. The widest part of the chest on the rib cage you see, that is C. A plus B divided by C is cardiothoracic ratio. Let us say here A is 3.2, B is 6. If this 3.2 plus 6 is divided by 14.8 is the C is below. 9.2 divided by 14, 63%. So you can easily see with the eye itself, you can say there is cardiomegaly. If you want to quantify, 63%, 55%. Normally 50% is the cutoff. Anything more than 50%, there is a CTR increase. Do you get it, Sudeshna? How to do the CTR? So practice on a few exercises, then you won't forget. CTR, don't say like that. Not a glance. Everything is to be quantified. Okay? Why? Quantification gives me prognosis. I treat the patient, I repeat the CTR, I know from 63 it has come to 55. I can say a patient is improving. Or you give the treatment is not responding, from 63 it has gone to 69, means the treatment is not working, it is resistant heart failure, something else is missing. Patient is taking NSAID, patient is taking CCBs, or patient is having some other disease. You have to see why it is not responding. Refractory heart failure itself is a separate topic. Okay. Now, what are the other signs? This is the alveolar edema, that is the bat's wing sign. You can see like a bat wing, the bat wings and prominent upper lobe vessels, curly B lines. These are the curly B lines. Interstitial edema will because of that. And then the pleural effusion may be there, cardiomegaly. There are 4 signs in the chest X-ray you have to see. 1, cardiomegaly. 2, bat wing sign. 3, curly B lines. 4, pleural effusion, basal pleural effusion. I will show you the X-rays for each. You see here, you have got the cardiomegaly very much there. In this particular case, cardiomegaly is there. The lower X-ray. Here it is pulmonary plethora, bat's wing sign. So totally like, both sides it is completely this one. You can see here bat's wing sign very clearly. This is one wing of the bat. This is another wing of the bat. This is called the bat's wing sign. Okay. And then you see this is again the acute pulmonary edema, and that is the pulmonary plethora there around the hilum there. It's acute pulmonary edema. And then you can see here the, acute MI, pulmonary edema, butterfly distribution, like the butterfly or bat wing, complete distribution of that. You would not have seen curly B lines. I'll show you the curly B lines. You see here, basal congestion is there, full fuzzy hilum is there, basal congestion and little pleural effusions are seen on both sides, bilateral pleural effusions, because this is a transudate. It is not an exudative pleural effusion. How do you confirm exudate or transudate? Take protein. Protein will be higher in an exudate. Protein will be less, normal or less in the transudate. Now you see here enlarged heart, pleural effusion, mild pleural effusion is there. And you see here pulmonary plethora. You can see the pulmonary plethora. You can see this X-ray. And you see this is a child with congenital heart disease, a huge congenital heart disease, cardiomegaly. You can see in this pediatric. It's a very huge congenital heart disease. Then you see now the curly B lines. Can you see the horizontal lines? Can you appreciate the horizontal lines there on the screen? These are interstitial edema. This interstitial, this one interstitium is opacified. These are called the curly B lines in heart failure. Okay. So, investigations and diagnosis of heart failure. Symptoms of heart failure very important. Signs of heart failure, the support, some of the signs, lack of them, the oppose, response to treatment, and then ECG abnormality, X-ray importance, echocardiography, very important, necessary, hematological, anemia, you should never forget to exclude anemia in heart failure. Because if you don't treat anemia, heart failure will not improve. Why?
Anemia itself will
Already demand supply that problem. And the content that is going itself is also bad content, anemia. What the fellow will get? Peroxygenation. The breathlessness will not improve. Likewise, renal function, liver function, thyroid function, uric acid also are very important. Pulmonary function test to evaluate the lungs. Now, what are the advanced tests I have got for heart failure? Coronary artery catheterization, CAG, CAG is catheterization of the coronary arteries, coronary angiogram, stress echocardiogram, dobutamine stress test, cardiac MRI, scintigraphy, right and radionucleated ventriculography, SPECT scanning, LV angiography, and myocardial biopsy. This is a very rare necessity. Now, carefully you follow algorithmic recommendation summarizing the recommendations for diagnosis of heart failure. International recommendation, not my creation. Suspected heart failure, how? Because of symptoms, history, and signs. Okay, what do I do? Seek to exclude heart failure through ECG 12 lead and or natriuretic peptide where available, either BNP or pro-BNP. Okay, if the other tests that are required mostly to exclude the condition are chest X-ray, blood test, urine examination, creatinine, and then the fasting sugars, fasting test, and then the TFTs, LFTs, glucose, lipids, urine analysis, peak flow or spirometry or exclusion tests. Okay, both are normal. Suspected suspicion is there. ECG is normal. Natriuretic peptide is normal. Heart failure unlikely. Consider alternate diagnosis. If one of them is abnormal, one or more has symptoms, ECG abnormality or NT-proBNP, immediately do the echocardiography. Echocardiography, no abnormality detected. What are the abnormalities look for? I look for ejection fraction, systolic function, left ventricular dilatation, and then left ventricular hypertrophy, any arrhythmias during the study, any clot within the heart, any ejection fraction, preserved type of heart failure like diastolic dysfunction, pericarditis, pericardial effusion, and valvular heart disease, and old RWME, all can be detected in the echo. The echo is normal, no abnormality detected. Heart failure unlikely, but if diagnostic doubt persists, consider diastolic dysfunction and consider referral and repeat the echo after a week. Abnormal. Assess heart failure severity, etiology, precipitating causes, exacerbating factors, type of cardiac dysfunction, correctable causes needs to be identified. Consider for referral. This is the general pattern of this. This is a 240 slide presentation. We have come to some extent. So let us do it after. So we came up to 124. So we will have another couple of classes probably. We'll stop here. Because it's a very extensive treatment for heart failure, the subject itself. Stop here because it is 4 o'clock. Then we'll continue.